known as an expanded blastocyst, and that's a 4 on the Gardner scale. That's what ideally what we like to see on day 5, that or higher. From there, a small hole talking a little bit about embryo development, but we didn't get into too much detail about it. And I think that this week we could talk a little bit about how embryos are graded and how grading can affect their success rates.
Great. All yours.
Okay. And last week, I know that we did talk about grading embryos on day 3 for the clinics that do grade embryos on day 3. So just to reiterate, some clinics will look at embryos 3 days after insemination, and they will grade them. And normally on day 3, what those clinics are looking for are at least 6 cells in the embryo. 8 cells is ideal, but 6 or more is considered normal. They also want to see less than 20% fragmentation in the embryo, and they do want the cells in the embryo to all be around the same size. And that means that cell division is occurring at the same rate with all of the cells in the embryo. So that's what we normally look for on day 3. But what a lot of clinics do is they'll actually let the embryos grow for 2 more days, and they won't even look at them on day 3. So 2 days later would be day 5. That's 5 days after insemination. At this point, we're hoping to see a lot more development since day 3. So on day 3, we expect to see about 8 cells. By day 5, we're hoping to see over 100 cells. So there's very rapid cell division that occurs. And so what happens is those 8 cells or 10 cells that are on day 3, they actually start to cluster together and form something called a morula. That's Latin for mulberry, and it's just a clump of cells. And then what happens is a small cavity called a blastocyst starts to form inside of that morula. Once that cavity starts to form, the embryo enters the blastocyst stage of development. And at that point, we can start grading the embryo. So it goes from the cellular stage, also known as the cleavage stage, and then it enters the blastocyst stage. So on day 5, what we often see are embryo grading systems that consist of 3 parts. Usually it's a number and 2 letters. Sometimes it's a letter and 2 numbers. Sometimes it's 3 letters. Every clinic has its own system, but one system that's used pretty commonly is something called the Gardner scale. So that's what I'll talk about today. But just keep in mind that every clinic is a little bit different. So the Gardner scale consists of 3 criteria. The first is the stage of development, also called the level of expansion, and that is a 1 through 6 grade. So sometimes you'll see embryos that might be graded, 4A or something. So we're talking about that number that comes first. And again, that deals with the level of expansion or the stage of development. So a 1 on the Gardner scale is an early blastocyst. And that means that cavity has just started to form in the morula, and that cavity takes up less than 50% of the embryo space. And then the next stage is called the blastocyst stage. This would be a 2 on the Gardner scale, and that's when that cavity starts to take up more than 50% of the embryo space. From there, the cavity will grow to take up 100% of the embryo space, and at that point, it will be known as a full blastocyst. Now, at this point, the embryo hasn't actually grown in size at all. It's still the same diameter that it was even from day 1. But what happens after that full blastocyst stage is the embryo actually starts to get bigger in diameter as it develops, as the cavity gets bigger, as the cells continue to divide, and that shell or zona pellucida that surrounds the embryo actually starts to thin out. And so the embryo is growing in size, there's more pressure inside of the embryo, the shell around it starts to thin. Once that shell starts to thin out, the embryo is known as an expanded blastocyst, and that's a 4 on the Gardner scale. That's what ideally what we like to see on day 5, that or higher. From there, a small hole will actually start to form in the shell of the embryo, and it will start to hatch from that shell. I compare it to a chicken egg. A small hole will form and it will slowly start to hatch out from the shell. So at that point, it's a 5. So it's a hatching blastocyst. And then eventually, that embryo will fully hatch out of its shell, and it will become a fully hatched blastocyst. And that's a 6 on the Gardner scale. scale. And hatching is important because embryos have to hatch in order to implant into the uterine lining. If they didn't hatch and they stayed inside of that shell, they wouldn't implant into the lining because there's an interaction between the cells of the embryo and the cells in the uterine lining that needs to occur in order for implantation to occur. So hatching is a good thing. And what some clinics actually do is something called assisted hatching, and that's whenever they take a laser and they just put a small hole into the shell of the embryo, and that just helps the embryo to hatch so we can assure that it is able to hatch from its shell once it's been transferred. So that's common for embryos that aren't hatching on their own. So that's the number system. Like I said, it's normally 1 through 6 on the Gardner scale, but every clinic might be a little bit different. Sometimes you might see something like XB for expanded blastocyst, or some clinics might use an A, B, C, D, E, F scale or something. So if it's something that looks different, I always just recommend asking your clinic how their grading system works. So that's the first thing. The second is usually a letter. So again, if we're looking at an embryo that's a 4AB, we're now talking about the part that's an A. So it's not the number, it's the first letter. And that refers to the appearance of the inner cell mass. The inner cell mass is a clump of cells inside of the embryo that ultimately develops into the fetus or the baby. And what we're hoping to see is a very compact mass of cells inside of the embryo. And if that's the case, we grade that inner cell mass as an A. That means that it is very compact, it's present, it's textbook perfect. If it's present, but maybe not perfectly compact, we give it a B grade, and anything that's below average is normally given a C grade. Some clinics also give D grades, and that normally means that it's not present at all, or it's degenerate or not alive. So that is your inner cell mass grade. The other letter, normally the last letter in the grading system, that letter refers to the appearance of the trophectoderm, and those are the cells that line the shell of the embryo, and they develop into the placenta. And again, they're also usually graded on an A, B, C, sometimes D scale. So again, an A would be a textbook perfect trophectoderm. A lot of cells, they're very uniform in appearance, there aren't any gaps. B is that it's present and it looks very average. It might have a couple of gaps, but it's still a good embryo. And then C is below average, and D is either degenerate or non-existent. So again, for example, if you see a 4AB embryo, that means that that embryo is at the expanded blastocyst stage of development. That's where the 4 comes from. It has a textbook perfect inner cell mass and an average trophectoderm. And a lot of people get discouraged when they see embryos that aren't AA grades. And I always say, don't get discouraged. Is there a slightly lower success rate? Slightly, but something to keep in mind is that embryo grading is subjective, and that means that it can change from person to person. So I might grade an embryo a certain way, and the embryologist next to me might grade it a little bit differently. And neither of us is wrong. It's just that it's subjective. So I always tell people, try not to focus too much on the embryo grades, because at the end of the day, yes, they're a factor in the overall success rate, but they're only one factor to consider. Now, of course, if you have an embryo that is very poor in quality, yes, that will affect its success rate. But again, if you have an AA versus an AB or a BA embryo, oftentimes the success rates are not significantly different, and they're still good embryos.
So in case of a very poor embryo, right, does it make sense not to go ahead and implant it at all?
So every clinic will have their own standards. Some clinics have cutoffs for embryos will not be transferred. So for example, we wouldn't want to transfer an embryo on day 5 that's still cellular. That means that the embryo hasn't even entered that morula stage, and it hasn't shown any signs of growth in a couple of days. That's something that we call arrested, and those embryos are not recommended for transfer. If we have an embryo that is very, very poor quality and its chances of success are extremely low, they're typically not recommended for transfer. Yes. And then, that doesn't take into account too the genetic makeup of the embryos. And that's where we get into pre-implantation genetic testing. But if we're not focusing on that and we're just looking at an embryo based on what it looks like, you have have to go off of your clinic's policies and standards about what they'll transfer versus what they will not. And it's situational too. So if someone has a lot of really beautiful embryos, then you can be a little more selective on what embryos are being frozen. If someone has less embryos, then perhaps you're a little more lenient on what you're able to transfer or freeze. And again, that's case by case. Normally it's something that's discussed between the embryologist and the doctor, and they determine the best course of action.
Mm-hmm. That's great.